Okay, so here's the update for 621. And let's take a look. So from Eastern Virginia Medical School, Paul Marek wrote this article. It's actually pretty nice because it puts together the symptoms and viremia and why treatments are really not successful a lot of times. Because the viremia starts to go up around day 5. That's really when you start to have symptoms, but you're contagious more than likely 2 to 3 days before you have symptoms, which is really 5 days into the illness. The virus levels then start to go down on day 12, which is really 7 days. That's when you show up to the hospital short of breath. That's already almost too late for the viremia treatment because it's now pulmonary phase treatment related to the inflammatory response. So things like tocilizumab might work, even though he doesn't talk about it there, but things that are anti-inflammatory, dexamethasone, 6 milligrams a day for 10 days, that sort of thing would work when you show up to the hospital and you're short of breath, okay? So what he does say here, which is nice, is the symptomatic phase here, day 5, let's say, of disease, fever, malaise, cough, headache, diarrhea, that's the time to start antiviral treatment. So he gives an example, ivermectin, which is really exploratory because there aren't any significant studies showing that ivermectin works, significant studies. They use it in South America. I have a friend's father who was on 40 milligrams a day for 5 days. It seems like a very large dose because 3 milligrams is a treatment dose for scabies, or 12 milligrams for certain scabies. And the potential treatments that he goes over is vitamin C, zinc, melatonin, vitamin D. My own personal therapy would be, if God forbid I got it, as soon as symptoms arrived, I would take Valtrex, even though it's not studied. It was not successful for SARS-CoV-1. I did hear some anecdotal case reports here of testers that were testing patients and developed symptoms, and they took Valtrex because they had it for herpes, and the symptoms went away right away. So I would be I would take it along with colchicine maybe once every other day as an anti-inflammatory. Doxycycline has some SARS activity. Famotidine, ivermectin, I would probably take a one-time dose. Zinc, quercetin, vitamin D, and then consider melatonin. Uh, I would consider getting admitted for the plasma antibody. If the antibody was going to work, the plasma really would only work during the first week of disease. I probably would not take Kaletra and Prescovix, even though the only successful impressive study was a combination of Kaletra, interferon, and ribavirin, which was the only real successful antiviral study besides the remdesivir. It was probably more impressive than the remdesivir trial, but those were a combination of 3 drugs. And the problem with taking the protease inhibitors, is that you really shouldn't take colchicine. And if you're thinking about taking colchicine, then you might not want to take that, because once you take the protease inhibitor, you shouldn't be on it for like 14 days afterwards. So you got to think about that. Although I was enticed by maybe considering just taking Prescovix alone early on, probably wouldn't be bad. So again, that treatment really should be started. This is my little therapy potentially, would be right away. That would right away really means like day 4 or 5 of the disease, because that's usually when symptoms start. And then if there's still symptoms by a pulmonary phase, that's the time to start a medral dose pack, colchicine, famotidine. So let's say a week after the symptoms, you're still having a second bout. It's a little tricky. You have to be courageous to take medral dose pack at that time, because it's not officially recommended, but that's probably what I would do. If you take a look at the COVID-19 plasma, convalescent plasma in 20,000 hospitalized patients, the Mayo Clinic just published notice that the 7-day mortality is significantly better on week 7 of the trial than it was in week 1. Why is that? It was 15%, and then on the first week, and then week 7, it's only 5%, because people were giving plasma much earlier. As you get better, you start giving the plasma earlier. So the idea is, and this is a study that's by Dr. Sullivan at Johns Hopkins, he's starting it right now, and he's giving plasma as an outpatient setting. So people that are symptomatic, high-risk patients, and even low-risk patients, you can get convalescent plasma early on, or you get placebo. And the idea is really to hit it. The antibody should work if it's given early. Any treatment should work if it's antiviral early on. The problem is we've been treating so many patients and the virus levels are down. It's just an inflammatory response. We've had some success with tocilizumab here, whereas the official trial was negative. Maybe that was already started too late, perhaps. Okay, thanks for listening. All right.